often get a little bit delayed. So you're very welcome to this webinar, which is part of the Lunch and Learn series that we're doing for Deep End. We've invited people working in Deep End practices. We haven't invited people outside Deep End practice, so I think most of the people who've come now are actually working in a Deep End practice, but if you're not, no worries, you're welcome. So for people who haven't been involved before, Deep End is a movement, really. It's not an organisation. It's a movement that we started here in Wales about 18 months ago, and it goes along the lines of Deep End Scotland. Sorry, my granddaughter is shrieking in the background, apologies. Better than a dog barking anyway.
You might have that in a moment.
Deep End Scotland started in 2009 in Scotland, bringing together the 100 practices that were serving the most deprived communities. And there's been a whole number of Deep Ends right across the UK, I think Belgium, New Zealand, Australia. So it's kind of an idea that's caught on, and they're multiplying thick and fast. So we're delighted that we started one in Wales with the support of Welsh Government up until the end of March. We've got support, and hopefully that might continue. So we've had a number of sessions where we brought people together from the practices to kind of share experience, share challenges, and try and work out what is it that we can do to improve the health of our populations, people that are registered with our practices, and the communities that they live in, and particularly vulnerable groups, health inclusion groups, because there's a big overlap with some of our Deep End practices. So there is an active steering group, and if people are interested in knowing more, there's a web page, or you can email Melanie Peters, who is our project manager, for more information if you want to get more involved. But this particular Lunch and Learn, we thought it would be very helpful to think about how do you understand your population, because the whole point of Deep End is to improve the health outcomes of the people that we're serving. And it's keeping ourselves above water at the same time, because we know the pressures in Deep End practices with the higher workload and the less resources. We are all in the Deep End, patients and staff working in the practices. So it's understanding what is it that's going on with your population, and how can you understand that better in order to put services in place, change your services and respond to those needs and actually make a difference. So I'm not an expert on this at all, but Sara and Gemma, who are my colleagues, consultants in public health and Cwmtaf Health Board, have been doing a lot of work on this, and we're delighted that they're going to come along and just share some lessons in how you understand your population and how you make that useful to make decisions and make changes. So I'll hand you over to Sara and Gemma. You've got a presentation. We're hoping that we've got about 20 minutes, half an hour, and then we'll be open to questions and discussion after that, and we'll finish exactly at 2 o'clock, because I know people are busy, so we'll keep to time. So Sara and Gemma, over to you.
Thank you.
Yeah, thanks very much, Kathrin, and thank you for the introduction and building us up. We are no experts. We've just had a bit of experience in this space. I'm just thinking I can't see anybody on the screen. Oh, I've got a bit of a better view now. That's okay. So yes, thank you for the invitation, and it's great to have the opportunity, albeit over lunchtime, to sort of share some of our experiences and perhaps some initial thinking that you might find helpful with regards to understanding your population. What we've got, Gemma and I, is a couple of slides that we've essentially split into 3 parts. We talk a bit about sort of what population we're talking about, what's the population of interest, how perhaps we could be using data, some examples we'll bring into the conversation, and perhaps some resources that you might want to go back and look at separately. And then we'll finish off with some of an approach that we've been taking in CTM, which is targeting our sort of interventions, something called population health management, that some of you may have already had some involvement with, but Gemma will certainly say a bit more about that then. So hopefully that sounds of interest. I'll kick off then with just thinking about our population. So what population are we really thinking about here? What are we interested in? It could be our practice population, and you'd be very familiar with your practice, no doubt, and the registered population that exists there. Or it might be bringing a number of practices together at a primary care cluster level, and that could be anything from between 20,000 population up to, in some clusters, 100,000. Then you could have, at the next level, clusters that come together at a local authority footprint, or localities as we're calling them. And then ultimately, of course, health boards could be, again, a number of local authorities coming together. Or it might be something that is not a specific geography area. It might be sort of a community or a population of interest, such as your collective populations as GPs serving practices in a more deprived population and part of this steep end project. So there's any number of different populations that might be of interest, but important really that we're clear about how we're defining what we're interested in. And I'll just put this slide in quickly, because I don't know to what extent people on this call will be familiar with the primary care cluster and the locality sort of concept, but this is just illustrating for our patch where we have 8 primary care clusters, to which our our GP practices are linked into one of these. The 8 clusters then are all linked to local authorities, of which we have 3: so Bridgend, Rhondda Cynon Taf and Merthyr, and then those 3 local authorities then are coterminous with our health board footprint. So knowing sort of where we are, where we belong, and who the population is, important. The question I would pose to you, and it's probably a bit difficult in a session such as this, but when we talk about your practice population, how well do you know your population? I probably should have a bit of a Mentimeter here where you'd perhaps given me a score from 0 to 5, but I would guess that you're probably very familiar with your frequent flyers and will probably no doubt know them all very well and on first name terms. So we probably know those individuals pretty well. And we should know, again, that there's the people who are on our chronic disease registers or registers of some description. We'll have an idea of who they are and what their needs are as well, to a certain extent. But what about the rest of the registered population of the practice? Those people who come nowhere near the practice, so we don't really know necessarily what's going on with them. I've called them here the well population, and indeed they are the current well population, but they really are those individuals that will slowly, with time or with particular events, will raise up to become the registers and indeed the frequent flyers of the future. So thinking there about what is the potential for prevention amongst that cohort of your practice population, and how well do you know what their needs are. So the kind of things that we might want to know about our population, well, the demographics, so the age structure, distribution, male, females, etc. The deprivation of the areas that we're serving. Now, by definition, the fact you're in today's conversation, you are in quintile 1 of GP clusters, so GP practices, but obviously not every patient within your registered population will necessarily be living in what we call a deprived population. We will have pockets of less deprivation and more deprivation, even within a smaller practice catchment area. Outcomes, Kathrin referred there to, knowing what the outcomes are for our patients and obviously working towards optimising those outcomes. So things such as how many years people are living, life expectancy, but probably more importantly, how many of those years they're living in good health. Chronic conditions, both prevalence and how well we're managing them perhaps. And then the things then that are sort of determinants of that, including the lifestyles and health behaviours, immunisation status, other sort of preventative activities that we would want to know to what extent our population are taking up these offers. Also, moving outside of health, we're familiar with the social determinants of health, but there are really interesting sort of intelligence data sources that link with education, housing, and we'll touch on that shortly. One of the things that I think is very important to us, within the sort of GPs of the deep end, but also from a public health point of view, are where we have inequalities in outcomes, but in terms of opportunities and resources as well. And the one thing that I would like to make sure that we do touch on, perhaps in a conversation at the end in our discussion, is to what extent we feel that we're actually listening to our patients and our communities and their lived experience, and to what extent we're including that in our assessment of need of our populations. So I'm just going to run through a few examples of data that sort of relate to those headings I've just run through quickly. The first one being around sort of a population structure, or population pyramids as we call them. This is a population pyramid of the population of Wales, and you can see you've got the sort of age ranges going up the y-axis, and then the size of the population in each of those age ranges. So that's my comparator for Wales. If I now show you some data for Merthyr Tydfil, you can see that the females are the red to my right, and males to the left. So you can see that there are some differences in the structure of the Merthyr Tydfil population by age and sex, but it's not vastly different. The smaller population, or the more granular population of Gyrnos, which people may know is one of our most deprived areas in Merthyr Tydfil, that is actually a large council estate surrounding the Prince Charles Hospital, District General Hospital. And when you sort of go down to this level of data, you start to see now the makeup of that population is quite different. We've got lots of younger age individuals, so lots of children, and we've also got sort of skewed towards more female young women as well. Fewer elderly population, but this is really helpful information to know what kind of services we need to be thinking about providing, and what the needs of that population are likely to be. More around sort of parenting support for children, but also around sexual health and reproductive health within that population. Give you another example of data that we have, and I'm sure you've seen versions of this in your local areas, but this is a map of Cwm Taf Morgannwg here, and it's the shades of blue relate to the quintiles of deprivation. So the darker blue areas are our most deprived areas. This can be presented also in the table here. Now we've tended to choose not to look specifically at the most deprived, quintile 1, but we're also looking at quintile 1 and 2, and perhaps we'll have opportunity to discuss that further later as to why we've done that. But you can see from that local authority level data that Bridgend actually, as a local authority, looks to be, less challenged by deprivation than perhaps Merthyr Tydfil and Rhondda Cynon Taf are. But when you break it down to a lower level, so going down to cluster, and when we analyse it there, you can see that it actually identifies that within Bridgend there are some stark differences in the levels of deprivation between, for example, Bridgend North and Bridgend East. So the level to which we sort of explore and investigate this data can be quite important, because it can unmask more of a story then, the deeper we go into the data. Another example, inequalities in outcomes. This is this is data for CTM as a whole. We can go down to local authority in this data, but nothing lower than that. And what you can see here, the left-hand side is life expectancy. The right-hand side is healthy life expectancy. And so you can see the difference between the number of years people live and the number of years they live in what they deem to be good health. And there are differences, and there are obvious gaps there between the most and the least deprived areas, but also to highlight that, you know, it could be up to 20 years that somebody's living in what's deemed to be poorer health. So, you know, what implications does that have for the individual, for their families, for society, their contribution to society, but also importantly, demands on our population, our services for our practices and wider services, and also, you know, for our staff who are also residents in the area too. I just put that little reminder there. Obviously, this data that I'm showing here was pre-COVID. The data has been released very recently by ONS, and it's had a deterioration as a consequence of COVID, which is not unexpected, really. Okay, so I'm just going to sort of highlight now some of the other lifestyle and chronic condition data that is perhaps would be of interest and relevance to you in planning. So National Survey for Wales produces survey data on lifestyles and behaviours. There's an example there that goes down to actually sub-local authority level, but the numbers become much smaller the lower you go. Data on then some of the sort of, well, overweight and obesity, child measurement programme, as well as survey data included there. There's data available on the uptake of vaccinations. You'll be familiar with these sort of COVID data and IVA data. So that can be quite helpful to get a sense of uptake within the practice. And then things such as cancer incidence, now that's reported lowest level at local authority, but our activity in screening uptake by our patients then can actually go down as far as practice level, and I'm sure many practices have looked at that data and are actively working on it. So just to explore a bit further some of the other aspects of data, which is around inequalities, and, you know, I mentioned earlier about the importance of getting that sense of the lived experience of the individuals that make up our population. And this is an example here of how we've got some other data sets that show where, for example, there are issues around energy efficiencies within properties, so housing related data. And I don't know how well it's illustrated in these particular maps, but, you know, we can identify that some of the greatest scope for improvement in energy efficiency and hence cost of heating is in houses in some of our more deprived areas. So appreciating some of those things might be helpful. And then there's an aspect of inequalities relating to, again, lived experience of transport. Colleagues from Bridgend will have seen this data, but it tells the story of one of our registrars who was a resident of Barry, who was working with Jeff up in Woodland Surgery for a little while, and he recorded his experience of trying to commute by public transport from Barry to Woodland Surgery, and contrasting it with his journey to the offices of Public Health Wales in Capital Quarter in Cardiff. And essentially, the experience of commuting from Barry to PHW was really, you know, not a costly journey. You know, the cost of the journey was £145, but quite a comfortable place to sit and wait for what was actually a very frequent service. Whereas the journey from Barry to my stay again wasn't, you know, was quite comfortable. That's £5.80. But the last part of the journey from my stay up to Woodlands was he had to stand and wait at the side of the road for a bus that didn't turn up and was very infrequent, and at a cost of £4 for a very short journey on a bus. So, you know, it's appreciating some of those things and the challenges that our patients experience in getting, for example, to hospital appointments. Another piece of work we did in Llinvi Valley was looking at bus timetables, and what that showed was that the earliest resident of Maesteg who needed to get to a hospital appointment by public transport, the earliest they could get to Princess of Wales in Bridgend was 11 o'clock in the morning, and you know, implications that has for the services that we are providing. So I'll quickly run through this next bit, and that is about the importance of what we do with this intelligence, the needs of our population and how that might fit into a planning process. What you see here is sort of one sort of illustration of how a planning cycle might work. Not all of these steps are always necessary, but essentially, you know, we've got the need to identify the situation, or it might even be a problem, but essentially capturing what it is we want to look at. Then we've got the process of undertaking a needs assessment for the individuals, the population who are utilising that service, for example, or who exist within that cohort of interest. But really important that we collect the appropriate data, and that we also look for qualitative data as well as quantitative where we can. How that data then and those relative needs can inform the prioritisation of what we plan to do, because there's never enough money to do everything, but you know, help in that prioritisation. And then how we draw in the evidence base for those interventions, and then employ them into a logic model of what we would anticipate the intervention to deliver then in a logical way. And then ultimately how we might use some of this outcome data or some of these metrics in our evaluation framework, excuse me, to know whether we've made a difference or whether there's still need for further change. And I'm sure that's something, you know, that you will have used in some shape or form, even if not as described in that way. And planning happens at all levels, you know, whether it's our practice plan, whether it's the cluster plans, health board, IMTPs, or integrated medium-term plans as they're called. But important is that the data isn't always available at more granular level, excuse me, but it's knowing where we can get the data from and to what level it does, it is available without compromising sort of information governance requirements, etc. And so that leads me on to just a few sort of considerations when we're looking at understanding our population and planning for our population, is that data granularity that I just mentioned, but also are we looking at our registered population? So in other words, individuals who are registered with the practices that can then be aggregated up to cluster and locality area, or are we talking about the population who are resident within that area? You know, there might be practices and where all of that is coterminous, but certainly on our patch we have areas whereby patients are registered with the population in our health board, but they're resident in another health board. So just to be aware of that, and also how the Office of National Statistics uses what we call small area geographies, which is essentially the population of Wales is split up into just some 1900 small areas, and each of those small areas has between 1,000 and 3,000 resident population. And so often we use this geography of lower super output area, it's called, that then becomes aggregated to middle super output area and above. So it's just knowing that, you know, when we're looking at the data, is it exactly coterminous with what our practice, or is it just, you know, close enough and good enough? Also, you know, they often use the estimates being used, particularly in terms of population, census population data. So that's worth bearing in mind. The time period it relates to. Unfortunately, a lot of the data that is routinely published often has a sort of a time lag, and it feels that it's sort of out of date, whereas perhaps data at practice level can be far more timely often. And I suppose the other thing just to flag is that some of the data is survey data. I mentioned earlier the National Survey for Wales. That's fraught with issues really in terms of reliability of responses, sizes of samples, but you know, it's the best we've got, and hence that's what we would use. Okay, so I'm rushing through this, but we will have the slides available for you as well to look at. So where would we go for this data, sources of data? Well, you know, as we've mentioned, there's a lot of stuff already within the practice on your clinical system, accessible via Audit Plus. You've got prescribing data. There's a lot that's you know, I'm sure you are already using. There's more then in the primary care information portal, perhaps access to national audit data that might be of relevance and interest. At health board level, you know, there's a number of us there who have access to wider data sets, but not only data sets, but you know, when I mentioned earlier about the value and strength of having the patient perspective or that sort of lived experience, there are things that we can sort of help with in terms of you know, whether it's focus groups or whether it's sort of systems mapping, etc., all of which add a richness to the understanding of the needs of the population. Stats Wales, there's a lot of stuff on there, particularly about populations and practices relating to deprivation that I'm sure you've looked at. Public Health Wales and other organisations produce publications from time to time that are useful, some of which go down to cluster level. But there's also now a new dashboard that's being developed. It's still in its sort of pilot phase, but the idea there is that that will provide a dashboard that you can sort of access. The other one I think that is quite helpful is the Primary Care One website hosted by Public Health Wales. That's been around for a couple of years now, and there are certain topics and tools that were developed and put on here to help, particularly with cluster planning. But you know, when you look through it, it would, I think, be useful at practice level as well. It's all about sort of resources that would help. It is sort of under review at the moment, and so there's opportunity either individually or collectively, perhaps as a deep end project, to influence what kind of tools might be useful and topics indeed going forward. So perhaps, Kathrin, that's something to explore further. Okay, this is just added in to highlight some of the wider data sets that are available that you might find of interest. So, for example, there's one here around school health and the behaviours and sort of attitudes of young people in schools. Obviously, that's only available at a local authority level and the individual schools, but it's also sort of provides useful intelligence. I brings back to deprivation here, in terms of, you know, as I said, the inequalities that exist, and that just brings me on to something that I know is very relevant to the audience here today, but I just wanted to perhaps run through this slide before I hand over to Gemma, and that is recognising the value of knowing the deprivation status and how that relates to the need of our populations, and how when we look at service development or service delivery, there's often a tendency to want to seek equality. So, for example, making sure that every cluster in Bridgend has exactly the same level of social prescriber resource, for example. But that really isn't cutting the cloth as far as we're concerned. The alternative situation that I think we've encountered, and obviously Julian Tudor Hart highlighted this, some 50 years ago, is the situation whereby the provision actually is it goes down as the need increases, and how market forces often dictate that to be the case. But what I want to leave you with is an approach or a concept that Professor Sir Michael Marmot introduced a few years back, and this was about proportionate universalism. And this is what we're really trying to seek here in the work that Gemma has been leading on population health management, which is around trying to tailor the service provision to the need of the population. And that by doing that, we can better target our resources. But to do that, we've got to understand the population and the need of that population. So I'm just going to hand over to Gemma now. Are you able to take over, Gemma, or do you want me to just do the slides from this end?
Right, I think I've requested to take over. If this is going to work now, let me just test.
Okay.
I mean, just to say to people, if you've got any questions, maybe keep them till after Gemma has finished, okay. Or you can pop them in the chat if you don't want to ask directly. So fire away, Gemma.
Okay, thank you. Yeah, so I'm just going to build on what Sara's introduced in terms of the getting to the point where we're understanding the population and the granularity and the level of need that exists in the population. So as Sara's alluded to, we've got the definitions there. So as always, I go back to these. We start with the definition of public health that I think probably a lot of you are more familiar with. But what we've been talking about more recently in the last few years then is looking to moving to a sort of population health focus, which is where we're looking at improving the health and well-being of populations, and in that is including an evaluation and reducing health inequalities within those populations. Now, one of the ways of doing this is by using a population health management approach, and within that, what that management element of population health management means is really we need to be coming at this using data-driven planning and delivery of care. And this is looking to impact or impactability then. So what groups of our population are we most able, have most capacity to benefit? And it's looking to redesign and refocus services to align with that. Now, quite crucially, population health management really does depend on that linked patient level data. And I suppose that's really a starting point, because without that, we won't be able to assess with any sort of detail our population. And what we do is we can use the linked data to both segment the population, which is where we divide the population up into similar groups, so we can help break those down to subpopulations to start tailoring care, but also looking at modelling of risk and risk prediction. So we can again look at targeting care. And in Cwmtaf Morgannwg, if this does change, we've been working on a population health management approach in alignment with some of the national conversation around developing a national framework for population health management. So this is the reason I'm putting this slide up, is when we think about population health management, when I first came to to lead in on this program. I think the focus was very much on that central column around intelligence, but intelligence for intelligence, you know, data for data's sake doesn't work. It has to have information for action. So what we wanted to illustrate is right from the outset, this population health management approach is separated into these sort of different capabilities of that systems leadership type role, working in innovation. Yes, the intelligence, because it can't happen without it, but also quite crucially is what the implementation of that looks like. And that's not all sitting, you know, that doesn't sit within public health. Ideally, it's the whole systems approach to looking and collaborating to redesign systems. So in Cwmtaf Morgannwg, as I said, we've established a linked primary and secondary care data set for all GP practices bar one. And what we've done is we've applied this segmentation model, which broadly divides the population into 10 segments, ranging from very low need to very high need based on chronic conditions and healthcare usage in the past and currently, among other factors. And we can start to build up a picture of the population in these individual segments to start saying, well, who do we need to look at targeting for the different services? And I can give you an example of one of the first projects we put into operation was a winter pressure and fuel poverty project in one of the clusters in Taff Ely, which has pockets of deprivation. It's not our most deprived cluster area. However, like Sara referred to, there are sort of islands of deprivation within that. So what we used was a combination of clinical records and it's PSRS, stands for Population Segmentation and Risk Stratification data. So it's essentially our population health management data and our models with the combination combined with the clinical records to target those living in the highest areas of deprivation within the cluster, with frailty and with who possess one of a number of the chronic conditions that you can see there. And we worked with the frailty service that was currently in place in the cluster to sort of to refocus their case lists and to look at a preventative approach and a what matters most conversation, and then refer on to their appropriate services and usual care. I won't go into a great amount of detail because there's not really the time, but I'm more than happy to talk about this at length if anyone wants to explore it further. But I wanted to just include a case study from one of the patients that went through this, because I think some of the value of population health is we're looking more at prevention and early intervention. So we're looking at that need versus the demand at door. So this was a gentleman who was identified with an EFI, an electronic frailty index of mild, wouldn't necessarily have come through a priority list in the frailty service, but did turn up in this project. Has cancer, he lived alone, was worried about keeping his car, keeping up with cost of the fuel bills at home, but with care planning and follow-up with the frailty team and social prescribing and other services, we were able to turn that around, and he was able to remain independent and make his clinical appointments as he needed. And that just sort of illustrates some of the value in being able to target and to identify those who have not yet hit crisis point and not yet had an escalation of their chronic conditions. I think, Sara, do you want to pass? I'll pass you back over to this for this slide.
Yeah, okay, thanks, Gemma. So essentially, just to sort of draw that to a conclusion, you know, in summary, you know, what can we collectively do, and you know, you as participants on this call, it's about, I think, firstly understanding our population in relation to the issues that we have. At what scale, you know, is it at practice level? Is it at one of the other sort of levels that we referred to? So knowing what data's there, but also using that effectively. And I can't stress enough the importance of listening to our communities and what they are telling us, and looking at ways of capturing that in our plans and in our voices back to our partners. On that note, developing and enhancing partnerships that will deliver across the system. Again, but understanding needs in relation to the services that are being commissioned, and how we cooperate in that space. And then just finally, the concept of aligning delivery to need and targeting the interventions in a proportionate but universal way, so that we've got a way of addressing some of these most challenging situations going forward. So I think that's all we wanted to say. But we probably, well, I've particularly taken up more time than planned. But are there any sort of comments or questions that anybody would like to share?
Do you want to stop sharing the
yeah,
presentation?
okay.
Then you can see more people, I think. And if people just want to switch their camera on and wave at you or put their hand up. So Maya, I think you made yourself visible in order to ask a question.
Well, no, just to say a big thank you. And, this sounds really exciting. And because we've got so many deep end practices in Cwmtath, I think, working together and doing some sort of collaboration would be really, really helpful. I think the interventions that you've done have been exciting and things that really matter to people, because this is one of our worries with the deep end, is that projects get put in, then disappear, just as they're working, and that things get put in from the top down, which may not be what our practices and what our patients, what's most important to them. So yeah, so thank you very much.
Maya, do you want to just say who you are?
Oh, I'm sorry. I know, Sara. Clinical lead for joint clinical lead for the Deep End project, and I was a GP in Pontyclun for many years.
Yeah.
Anybody else got a burning question? You're stunned into silence. But I'll jump in and ask a question then, what people are thinking is, when we're sitting in deep ends, our practices are across at least 4 health boards, about a quarter of practices in each of 4 health boards, and a handful outside that. And the data is given as a resident population mostly, isn't it, and being used place-based. What is it that you think might be useful that Deep End could do from where you're sitting? What is it that Deep End would be able to do that you can't necessarily do at that sort of small population level, or even at health board level? Anything you could advise us that would be worth us focusing on?
Should I go first, Gemma? Yeah.
Go on then, Sara.
Okay. Yeah. I just thinking in terms of what I've highlighted there, the strength of both quantitative and qualitative data. I've called it the lived experience of the patients, also the lived experience of practices as well in delivering those services, and how collating that will is very, very powerful. I think some of what we showed is available in CTM because we have developed this approach, which isn't as yet, I stress as yet, available across the rest of Wales. So we're sort of limited there in terms of some of the granularity of things such as the chronic condition, prevalence of chronic condition, etc. However, I think picking perhaps a theme in all of this might be helpful, and looking to see what is available, what evidence, what data do we have, both qualitative and quantitative and qualitative, that will sort of add to the case then that you're telling. Because I don't know if Jeff Smith is on the call, or any of my colleagues from Llinvi Valley. I'm not sure if there is anybody, but we've really been pushing on this sort of lived experience angle to complement the data then, because, you know, numbers and figures go so far, but actually understanding what that means for individuals is far, far stronger. So we're focusing on that angle, and perhaps that's something we can look at. Well, okay, so where do we need to make the case? You know, we're working locally because we feel that sort of the Bridgend Joint Partnership Board and ultimately the PSB and the Regional Partnership Board are where we want our story to be heard, and that's how we're going to achieve progress there. Whereas it might be that collectively there's a lot more sort of from the breadth of deep end experiences that could then be that kind of approach replicated, but taking it back to Welsh Government, for example, or, you know, to the strategic programme for primary care. So I think it's about scale and what population are we talking about, and I think bringing it together collectively and aligning efforts will be really, really powerful.
That's really helpful. I noticed that before you come in, Gemma, is Alda, you had your hand up, and I think being in deep end but also a cluster lead, it'd be really helpful to hear what you think.
Yeah, I was going to come in with those two hats on, actually, to be honest. Thank you for that presentation. It feels quite empowering to know that data can change things. But I think I was coming from a perspective of that I'm in a cluster where 4 of our practices are in the deep end, and 1 just happens to be lucky enough to just slip below the cutoff. So, sort of from my perspective, it sounds like utilising that collective voice is really important, but using that data to make your voice louder. And it just be interesting to figure out how we do that, because as I think Kathrin has said, when you're working in the deep end, especially if your resource is low and your demand is high, it's very difficult to get that headspace to do it. But also with my cluster lead hat on, what we quite often find is if we go with the data of there is more need for this, then there will always be the reverse, people shouting, but there has to be equal access for all. You know, that is the Welsh Government's policy, you know, we should have equal access for all. So it's that, how do we raise our voice and enable that proportional universal? We're a Marmot region, I'm a GP in Iron Bevan, I'm in Blaenau Gwent East Cluster. So we are a Marmot region. We should be using that resource not in an equal level, but more equitable, to raise everyone up to the level of, I'm going to say it, Monmouthshire. So sorry, it's an in-joke and an Iron Bevan, but so it's just about how we do that and how we utilise that resource, how we get that collective voice. And I just want to say, God, that public transport thing, that was, I was sitting there thinking, you cannot get 1 bus to any hospital from Abertillery. It is a 2-bus route. I can't get to work on time if I took public transport, because I can't get there for 8. That really resounded with me.
Yeah, yeah. And I think there, you know, that's the power of the sort of the patient experience, isn't it? Or should I say the citizen, the resident experience, that we tend to perhaps not really pay attention to. And, you know, that I think adds power to the equity argument. And, you know, whilst we're sort of signed up to the proportionate universalism approach, and you know, you were leading the way in Iron Bevan with your Marmot region, etc., you know, we've got to get that approach in at all levels, because, you know, when we talked about this in Bridgend, and what I illustrated there between the 3 clusters and the contrast, there was that sort of maturity of understanding that actually we can't carry on as we are. So one of the examples that or outcomes of that is that we had the local authority had a community coordinator resource that they had allocated per head of population. Having understood that, they've now realigned that to allocate more of that resource to the areas where it was needed. And sometimes it's just a case of people not understanding the story. So the more we can make that a living story, I think the better, really.
I think, do you know what? And I think just to build on that, I think there's an important point there for me is that that's crucial to that understanding of the population. If we're talking about coming away from a demand-led system to a more of a need-based system, you have to have that understanding of the population, because I've come from a meeting this morning with an advanced nurse practitioner leading our acute clinical services teams in the community, and he's having the same conversation to say, well, how do we have an assessment of what our base need is before it lands at our door? We're very, by nature a reactive service, but we want to be able to understand who's going to come in order to prevent the hospital admissions and to have avoidance rather than dealing with that demand. And I think it does go back to I'm a big proponent of shared care records, and I'm trying to have conversations with the Chief Digital Officer for Wales and various information governance leads to look at where we are as a nation to be able to be in a position to better understand our population, because I think we won't be able to do that functionally, but in terms of assessing need, until we get to a point where we can say, right, we are following Miss Jones through the system. We all know what's happening with her. We know when we've got a flag on that we can identify her when she's reached a certain individual crisis point. Comes back to sort of prudent care, healthcare principles and value-based healthcare around, patient-centered care. So for me, it's, it is having that conversation in the right places, like Sara was saying, and in the new accelerated cluster development model is, where does Deep End sit in that new accelerated cluster development model, where you've got different clusters with different proportions of Deep End? Because if it's just one practice, there's a different level of voice. So I suppose it's using that forum, or the fora available to us, in the most effective way.
I was going to say, at least for once, I feel that because we're all Deep End practices, I feel in a good position.
Yes, yeah.
We're hearing that from other practices that are not the majority. Deep End practice where there's only maybe 1 or 2 or 3 in the cluster, that they're fighting the corner always to get that understood about equity rather than equality. So yeah, maybe that's something that Deep End, we're probably using data for advocacy rather than planning, which is where you're driven at, but they go very well. They're complementary, aren't they? So Heather, you had your hand up.
Yeah, sorry, I'll appear. Yeah, just a bit to echo that. I'm a cluster lead in Philly North in an RMBEV, a bit like Isolde. And again, my personal practice is not deprived enough to be in the Deep End, but we've got pockets again that are more deprived, and other practices are clearly deprived. And again, as a cluster lead, we try and make things equitable. And I just wanted to say that it is very hard to move the resource where the need is greatest, and I think the Deep End could definitely have a role in that to help prioritize. What's the difference between the areas of deprivation? What are the key differences? So is it smoking prevalence? Well, okay, let's have more smoking services in that area. It can be very simple, but there's the mechanisms to put that weighted resource aren't really there in a meaningful way, I don't think. Yeah. So it's practically to move the resource where the need is greatest, and the levers just aren't there. And I think that would be a very good role for the Deep End to really identify where things need to be moved and how to do that.
Yeah. Can I also come back in on that? Yeah, I agree entirely. And there is a programme of work at Welsh Government level on tackling health inequalities. That this population health management sort of approach that Gemma described is one of the sort of work streams of that inequalities approach. But I think what I think is important when we talk about individual practices and clusters is the data that I showed for Bridgend. When Bridgend joined Cwm Taf to form Cwm Taf Morgannwg, and you just look at the sort of headlines for Bridgend in terms of the average sort of deprivation, it doesn't look too bad. But it's only when you start digging underneath that and you appreciate the challenges that one part of that local authority, i.e. Bridgend North, faces. And the same could be true for the clusters you're describing, where there's just one or two practices. If we can get people looking on at not achieving equity, but let's unpick to identify where there are inequalities. Even if it's one practice to 5 or 6 others, there still is that inequality that we've got to shine a light on.
Yes, like the transport element, in the example given, something as simple as that. If people can't get to where the jobs are in an area, then clearly that's going to have an impact on income, which has then all the ramifications of that. Well, that needs to be an area of focus of the local authority, Welsh Government, etc. So how to, it's a big system sort of change, isn't it, to get everything joined up to put the right resource in where the maximum need is. And it's so wide-ranging, really.
Yeah, the accelerated cluster development approach and the sort of pan-cluster planning groups, what they call joint partnership boards with us, gave me a lot of encouragement, thinking that we will sort of have a forum then by which we can bring the cluster stories in or have a sort of a mature conversation with people who have access to the resources or to how the resources are deployed. But, certainly on our patch, it's yet to really sort of realise that ambition or to be clear as to how exactly that would work. But I know, the ambition described by the strategic programme has all that in mind, but it's just, it'd be nice to see how that works. And also, as I say, how the deep end as a movement can help sort of influence in that space as well.
Brilliant. I mean, we've got 2 minutes to wind up. So that's a lot of food for thought. It really has been useful and really stimulating. As Deep End, when Maya is here and Peter Saul as co-leads until the end of March, and then we're going through recruiting new leadership. So Deep End's going to carry on regardless of however much funding we get. We're just going to carry on and do our best. But we have engaged with the associate medical directors and the heads of primary care and the health boards and the directors of public health. So maybe we need to go away and have a real think about what is it that we can do as Deep End. What do we need to maybe explore to tell the story that we can go to a more strategic level. So there is kind of what can you do at cluster level? All of us, in Deep End practices at cluster level, but what is it you can do together to tell the story? And there's things like transport makes me really think that that's something we could maybe pick up and see what's the difference between all the Deep End practices and other practices, things where nobody's really comparing and looking. Sorry, Luke, did you have your hands up? We've got 1 minute. Oh, we've run out of time. But anyway, Luke,
yeah, sorry.
Away anyway. People need to go, they need to go. Carry on.
I was just wondering where the linking with the RPB, the regional planning boards, come in, and where, all of everything we're talking about here, the wider determinants of health, but actually, yes, we can work on as health as an anchor institution, but we need local authority where they have more power and control over these wider areas around planning, around transport links, access to green open space. And I think where we can use the work that you're doing along with then the work, using a PHM approach, and to identify then areas which should have a priority, where they start to develop some of those transport infrastructures, where they do prioritise making sure there's safe access to pedestrian areas to be able to access those facilities to take exercise and have better health and well-being. How can people take control of their life and their well-being if actually the system around them doesn't allow that? So I just wonder what space you've got and where you've made headway, or if not, maybe that's where Sara and Gemma can help with the RPB.
Yeah, that would be fantastic. I mean, as Deep End at the moment, it's just, I'm public health lead, but I'm doing one session a week at the moment, and that might finish. So we haven't got much capacity, but we've got loads of enthusiasm, and like people like Heather and Isolde, lots of people who are giving up support and time. So I think there's maybe something we need to focus on. What do we do to tell that narrative and the story that we need data for, and intelligence in its wider sense? And what you're doing would be really helpful and supportive. So maybe I'll go away and have a think about how we can take that forward when we've got kind of the lived experience in Deep End and you've got the expertise. Thanks, Isolde. So I know we've come to just on 2 o'clock. I'm really grateful for you, Sara and Gemma. That was really helpful presentation. It was just the right level for us to be really useful and not overcomplicated, and lots of ideas and lots of food for thought. So really appreciate that. Mel, we're going to put the recording up on the Deep End webpage. So
yeah,
I think quite a lot of people would have come to this if it wasn't in the middle of a working day, and it's always a challenge. If we put it on out of hours, then it's going into people's, own time. But at least people will be able to have a look at the recording, so we might get more questions coming through. So thank you very much for your time, and thanks to everybody for coming. We've broken our own record for a lunch and learn, so we'll go from strength to strength now.
Thanks all.
Everybody.
Thanks all. Bye-bye.
Take care. Bye.
Bye-bye.
Cheers, folks. Thank you.